Welcome to this series of videos on communicating with chronic pain patients. This is Module 3, Validation Without Reinforcing Disability. Imagine a patient with chronic low back pain tells you, "My back is completely damaged. Every time I bend over, I'm probably making it worse." What do you say? As healthcare providers, our instinct may be to correct the patient. No, that's not what's happening. Your back isn't damaged. Your MRI really isn't that bad. We may be completely well-intentioned. We're trying to reassure the patient. But there's a problem. The patient may hear something very different. "You don't believe me." And this brings us to one of the most important communication skills in chronic pain care: validation. Validation is not agreement. Let's clear up a common misconception. Validating a patient's experience does not mean agreeing with everything the patient believes about their pain. Those are two completely different things. Suppose a patient says, "My back hurts because my disc is slipping out every time I bend." I don't have to say, "Yes, you're right. Your disc is slipping out." That would be agreeing with their interpretation. But I can say, "It makes sense that you'd be worried about bending if you believe it's causing more damage." That's validation. I'm not validating the anatomy. I'm validating the patient's experience and concern. And that distinction is incredibly important. Why does validation matter? Research into chronic pain communication repeatedly finds that patients want to feel believed. A NICE evidence review examined 28 qualitative studies of communication between healthcare professionals and people with chronic pain. One of the major findings was the importance of validation and belief. Patients wanted healthcare providers to recognize that their pain was real and acknowledge the impact it was having on their lives. There's also research looking specifically at pain and validation. One large thematic analysis examined hundreds of published articles containing narratives from more than 7,700 people with pain conditions. 5 major themes emerged: not being believed, lack of compassion, lack of understanding, feeling stigmatized, and eventually patients even questioning themselves. Think about that last one. When someone repeatedly hears, "There's nothing wrong with you. You shouldn't be hurting this much. Your tests are normal." Eventually, the patient may begin wondering, "Is this all in my head?" That's not reassurance. That's invalidation. And here's what's fascinating. Sometimes invalidation happens when we're actually trying to reassure someone. Imagine I tell a patient, "Your MRI looks pretty good. There's really nothing there that should be causing this much pain." From my perspective, I'm saying, "Good news, your spine isn't badly damaged." But the patient may hear, "Then you don't believe how much pain I'm experiencing." Now watch what happens. The patient starts defending their pain. "No, you don't understand. It really hurts." And the provider responds, "I understand, but your imaging is normal." The patient says, "But sometimes I can barely get out of bed." Suddenly, instead of working together, we're arguing about whether the patient's pain is legitimate. That's a terrible place to begin rehabilitation. There's a simple principle that can help. Validate first, educate second. Instead of immediately saying, "Your MRI isn't that bad," try, "I believe you. I can see that this pain has had a major impact on your life." Then pause, and once the patient feels heard, you can add, "The encouraging part is that the amount of pain someone experiences doesn't always tell us how much physical damage is present. So the fact that you're hurting doesn't mean your back is being damaged every time you move." Notice what happened. We didn't dismiss the pain. We acknowledged it, and then we introduced a more hopeful interpretation. Validation becomes the bridge that allows education to occur. Here's another example. A patient says, "I'm afraid to exercise because every time the pain increases, I think I'm damaging myself." An invalidating response might be, "You don't need to be afraid. Exercise isn't hurting you." Again, our intention is good, but we're essentially telling the patient, "Your fear doesn't make sense." Instead, try, "Given what you've experienced, I understand why an increase in pain would make you nervous." And then, "Would it be okay if we talked about the difference between experiencing pain and causing damage?" That's a very different conversation. We're validating the fear without reinforcing the conclusion that movement is dangerous. Here's a simple 3-step approach you can use tomorrow. Step 1, identify the experience. Listen for frustration, fear, disappointment, or uncertainty. Step 2, acknowledge it. That sounds frustrating. I can understand why that would worry you. You've been dealing with this for a long time. Step 3. Create a bridge forward. And let's see if we can find a way to gradually get you more comfortable doing that again. That's the key. Validation doesn't mean leaving the patient where they are. Validation helps us meet the patient where they are so that we can move forward together. We also don't want validation to accidentally reinforce helplessness. If a patient says, "I can't do anything because of my back," we don't necessarily respond, "You're right. With pain this bad, you really can't do much." Instead, "I can see how much this has limited you. Let's figure out one activity that's important to you and see if we can gradually help you get some of it back." We're validating their current struggle while still communicating possibility. That's the balance, acceptance of the patient's experience combined with hope for change. When someone has lived with chronic pain for years, they may have spent years trying to convince other people that what they're experiencing is real. Don't make them convince you too. Believe their experience, acknowledge their frustration, recognize their fear, but remember, validation does not require agreement. You can say, "I believe that you're hurting," without saying, "I believe your spine is damaged." You can say, "I understand why you're afraid," without saying, "You should avoid movement." And you can say, "I see how much this has affected your life," while still communicating, "I believe things can get better." Validate first, then educate, because before patients are willing to reconsider what they believe about their pain, they often need to know that we believe them.